Good afternoon, everybody. A warm welcome from Nolex to today's special webinar, Innovation in Faecal Continence Care, the Balloon-Free Advantage. My name is Alan Chadwick, Head of Research here at Nolex. It's a great pleasure to have you all here today. We're going to kick off shortly with the first of our three presenters for you. We've got Chris, Teresa and Deanna. Deanna will be making a video presentation only. So we'll kick off very shortly. Before we start, a couple of sort of reference points of house notes, as it were. One, everything today is going to be video recorded, so all the recording of the whole session will be available in the next few days. So that'll be available. You've got communication from our team that's now available to as a video on demand. And in very simple terms, it's a very interactive session. So after the three presentations are completed, we'll begin to feed back into the presenters any questions you have. But you can provide your questions at any time in the notes section of the site. Bring those through, and we'll get through as many of those questions as we can in the time allotted. So with no delay, can I introduce our first presenter today, Chris Skilleter.
Thank you very much, Alan. Welcome, everybody. Obviously, today we are looking at innovation in faecal continence care, the balloon-free advantage. My name is Chris Skilleter, and I'm the Northern Regional Manager for iMedicare Limited. So, roughly 9 to 40% of all ICU patients are affected by faecal incontinence, which could further complicate their hospital stay. Poor faecal containment can result in hospital-acquired complications like pressure injury, C. difficile, catheter-associated urinary tract infections, or central line and bloodstream infections. The NHS in the UK spends roughly 1.4 to 2.1 billion annually on pressure ulcer care. Expert recommendations for managing acute fetal incontinence with diarrhea in the intensive care unit follows an algorithm. The diagnosis of acute fecal incontinence with diarrhea is specified as a second episode of fecal incontinence within a 24-hour period. With good prognosis, we will see well-nourished and hydrated patients, short hospital stay, treatable, and either mobilised or mobilising soon. This can be managed with traditional methods such as pads, incontinence sheets, or fecal collectors. If the patient is at risk of developing complications such as risk of skin breakdown due to moisture lesions, excoriation, pressure ulcer or burns, risk of cross-infection, commonly seen with C. difficile or MRSA, immobility, very frequent or long-lasting diarrhea caused typically by pancreatitis or hepatic encephalopathy, and other clinical conditions, as well as patient comfort and dignity, specifically in a palliative situation. With contraindications for fecal management, we will look towards the management with traditional methods, again through pads, incontinence sheets, fecal collectors. With no contraindications, we would refer to product instructions for use, inserting a fecal management system, evaluating every 12 hours, and making sure to cleanse, moisturise, and protect the skin. The UK addressable market, based on hospital statistics published by the National Centre for Health Statistics and the Society for Critical Care Medicine, the potential market has been estimated with a prevalence of 9 to 37% within critical care units, 30 to 50% in nursing homes, 9.7 to 12% from home agencies, 24 to 64% within hospice care, and 42 to 50% within residential care. People with regular or more severe fecal incontinence affecting their quality of life is estimated at over 500,000 individuals across the UK. Inadequate and incomplete solutions with regards to absorbent pads can cause constant exposure to fecal effluents, compromising skin integrity. 21 to 42% of incontinence patients can develop incontinence-associated dermatitis. Fecal incontinent patients are 22 to 37.5 times higher odds of developing pressure-related injuries through friction, moisture, and bacteria. Intrarectal balloon catheters have a higher prevalence of peripheral leakage, which leads to cross-contamination, higher pressures at the anorectal junction, which can strain the sphincter muscles, extensively reported adverse events leading to additional treatment costs or increased length of stay, increased susceptibility towards hospital-acquired conditions, complicating the patient's hospital stay. MOD report from 2013 to 2018 showed clinical complications including mucosal injury, rectal bleeding, pressure injury, anal erosion, and fistulas, with device limitations around overinflation, peripheral leakage, and device expulsion. So we're looking to upgrade to a safe and gentle solution for your patients, utilising the Qora system. The Qora stool management kit has a hygienic device applicator, which eliminates digital insertion, minimises cross-contamination, and standardises the application process. Odour-controlled transit sheath is specifically engineered to ensure odour-free stool diversion. The irrigation port for device irrigation and fluid administration, as well as a safe withdrawal mechanism, which can aid in safe and easy device removal. The sampling port at the midpoint is designed for hygienic stool collections. The flatulence release filter on the bag is there, an integrated filter for automatic odour-free degassing, and the odour-proof collection system isolates the stool with a one-way inlet flow valve. You can also see on the left-hand side the indwelling lattice in the deployed state, which will allow for normal physiology and improve safety and comfort. Unique to Qora stool management kit, it does not utilise sphincter toe muscles for device patency, which will allow for 3 times patient eligibility. Commonly with intrarectal balloon catheters, we are looking at tonic sphincter tone usage only, which means around 70% of patients who have atonic sphincter tone and fecal incontinence are unable to utilise. However, with the Qora system, they can be used with tonic or atonic sphincter tone. Hygienic applicator for safe device insertion will avoid digital insertion and cross-contamination and allows for precise placement of the device. 83% lower insertion force utilised. Large diverting lumen allows for management of patients with varying stool consistencies and has up to a 7.6 times larger lumen, which allows for better management of stool passing. Safe for patients and more user-friendly. The malodor containment applies complete device coverage from top to toe and will provide a more pleasant working environment, as well as a 3 times higher patient eligibility for use. The hygienic insertion will reduce cross-contaminations. It's tolerable by conscious patients. Significantly lower radial pressure allows for better comfort with patient use. Stool diversion allows for liquid to semi-formed, which is a 5 to 7 on the Bristol stool scale. Wider patient eligibility and potential for longer in situ use with tissue viability issues. The Qora system provides a good rectal seal, which can reduce device occlusion and peripheral leakage. There's no reported SAEs, which maintains natural physiology, preserved sphincter tone, and it's MRI compatible for 1.5T to 3T MR systems. So the calibrated radial pressure is seen up to a 74% lower pressure on the rectal mucosa and reduced risk of mucosal impairment and rectal bleeding. The Qora exhibits 21 mmHg of radial pressure, which is well within the safe zone. At 22, you can see compression of the mucosal arteries and blood flow impairment. At 36, the arteries can be occluded. The novel low-profile design avoids constant strain on the sphincters, and long-term use of intrarectal balloon catheter can weaken that sphincter tone. In addition to the higher position away from the anorectal junction, this can allow for better sphincter tone recovery. 29.6% of fecal incontinence patients exhibit adequate sphincter tone for ICB use. Therefore, over 70% of patients are atonic and are not able to use a balloon-based catheter system. Qora is designed to manage patients with both tonic and atonic sphincter tone, providing 3 times higher patient eligibility for use. The safer insertion with the hygienic applicator avoids digital insertion, and lower force avoids pain and discomfort for patients, with an 83% lower insertion force recorded. Complete malodor protection with the specially engineered polymers provide 100% containment of foul odor, which reduces work stress, medical errors whilst improving patient recovery within the environment. The large diverting lumen is between 2.7 and 7.6 times larger cross-sectional area, which reduces the risk of device expulsion and allows for a wider range of stool management. It's a short video introducing application, management, and removal.
Introducing Qora, a suite of stool management kits for bedridden patients with fecal incontinence and diarrhea. Position the patient so that the anal canal is easily accessible. Holding the applicator in one hand, generously apply lubricant along the length of the applicator. With the patient in left lateral position, ensure the white portion of the applicator is pointed toward the coccyx of the patient. Insert the applicator into the anal canal until the white stopper touches the coccyx. Firmly hold the white stopper against the coccyx and gently withdraw the green applicator sleeve towards yourself. Now remove the white stopper. The device is now fully deployed in the rectum. Position the collection bag hanger on the bed side rail towards the patient's feet with the hook facing outwards. Ensuring that there are no twists or kinks along the length of the device, the transit sheath is laid straight towards the foot of the bed. Ensure that there is an adequate amount of slack in the device. Excessive tension should never be applied to the device. The indwelling diverter conforms to the rectal wall, providing an excellent seal during use. The large lumen of the device allows varying consistency of stool to be collected. If a stool sample is required, open the sampling port cap and aspirate. Close the cap. Perform irrigation to clear the lumen and to facilitate easy transfer of fecal material. To irrigate the device, detach the cap. Attach a syringe filled with 20 to 30 milliliters saline solution and gradually depress the plunger. Secure the transit sheath near the patient's perineum with one hand and use 2 fingers of the dominant hand to drain any fecal matter into the collection bag. To exchange the bag, disengage the collection bag, by carefully rotating the bag connector counterclockwise from the transit sheath connector. To add a fresh bag, mate the collection bag connector to the transit sheath connector and rotate clockwise until they lock together. The bag is provided with a flatulence release filter to prevent ballooning. To withdraw the device, firmly hold the Y connector with your hand and use your dominant hand to pull the white cap towards yourself until the white tether is taut. The indwelling diverter is now collapsed in the rectum. Slowly retrieve the device by holding the transit sheath close to the anatomy. Dispose the device according to institutional protocol. To know more, visit www.consuremedical.com.
Useful to know that the 74% radial pressure was measured in vitro using linear tensile tester, showing that 22 comprises of mucosal artery impairment and 36 occludes the arteries. The insertion force of 83% lower and 49% lower withdrawal force was measured using linear tensile tester at the base of the rectal model. The IBC would damage the rectal model when trialled to withdraw without deflation. Systemic literature review revealed that only 29.6% of incontinent patients exhibit adequate sphincter tone for a balloon-based catheter use. Therefore, 3 times patient eligibility, including tonic and atonic sphincter tone. Qora is also a very cost-effective system and is listed on NHS supply chain at a remarkably lower rate than commonly used devices at the moment. The device comes in a pack of 10 with additional collection bags also coming in a box of 10 units as well. Clinical validation through multiple studies has been taken place. These should be available via our website, or you can request further details via your local representative as required. So try Qora to improve wound care, infection control, and maximise savings. You can contact the customer service team at any stage, and they will put you in touch with your local representative if you are not aware of who they are. Thank you for your time. The next part of this presentation will be delivered by Teresa. Teresa is an ITU Deputy Manager for the Northern Lincolnshire and Gould Foundation Trusts. Welcome, Teresa.
Hello, everybody. So we started using the Qora system in our high dependency unit and intensive care unit from December 2024. Most commonly, we use this device in patients that have got liver disease and patients that have got CPE or C. difficile. In the ITU, we use it a lot on patients that are sedated, having NG feed and laxatives. Next slide, please, Chris. Thank you. So I devised this questionnaire just so I could get feedback from the staff. We have a separate high dependency unit, so I distributed it across that unit as well, given that we mainly see a lot of sedated patients. And as you can see from the graph there, we found overwhelmingly members of staff found that the system was easy to set up and insert. Just a couple of members of staff found it was difficult, but that was perhaps user error. And then very easy to remove the Qora, which was overwhelmingly so by a whole team. Comfort levels for the patient, it did come out neutral. Mostly, obviously, we can't assess this on our sedated patients, but the awake patients, they did feel it's slightly uncomfortable when we sat them out in the chair. And the material for the external tube also, staff felt it caused a bit more skin-related issues and a bit discomfort in comparison to the Flexi-Seal. However, I think, Chris, there's going to be some changes made in the future, isn't there? Is that right?
So the area around the anus itself tends to be a softer material. The sheath itself could be seen as a little bit irritant to skin in a seated position, but yeah, we're always open to further consultations with Consio Medical, the manufacturers.
So as you can see from the graph there, that most people overwhelmingly thought that the Qora system was effective at containing the stool, with just a few people having different opinions. Again, there's a bit of a tie between the performance in reducing skin irritation and pressure injury risk, but overwhelmingly people felt it was good, or either neutral and weren't sure. So quite positive from that point of view. And comparing the two systems, a lot of people felt it was about the same. Only a very small margin of people thought it was worse. Occasionally, some expulsion of the system was noted, with a couple of people felt that may have been due to specific patient anatomy. With the next group of people was people that never saw any expulsion at all during use of the system. And then we just got some general comments from the staff. Again, they're talking about the first one, sitting patients out from a rehab point of view. We still limit the amount of time patients are sat out from having these devices in. Someone has also commented that the collection tube, they felt it was noisy and kinked quite easily. Again, there was a comment about occasional leakage, but again, this is somebody who felt it was anatomical, but overwhelmingly generally effective. A lot easier to use and manage in terms of the setup and removal. Definitely more cost effective, and slightly more comfortable for the patient as well, and less skin irritation, which is obviously a bonus.
Have you had much interaction with the tissue viability team and the Qora system?
No, not really. No, not at the moment. No.
Okay. And have you had any cases of mucosal injury or damage from Qora use?
None that's been reported to me. No, none that I'm aware of at all from either unit.
Fantastic. Thank you for your time and your involvement with that, Teresa. Very much appreciated.
I think there are some questions in the chat that I've seen going through.
So I think we've got a video for the Qora system to introduce that, and we'll get some questions at the end, if that's okay with you to stick around, Teresa.
Yeah, that's fine.
Thank you. So next we've got Deanna Vargo from Consio Medical, who will go through a little bit of information on Qora, which is a new system, and we will be introducing it to the UK market in the near future, but it's not currently available just yet.
Hi, my name's Deanna Vargo. I'm a wound ostomy and continence care nurse and have spent decades caring for patients with complex needs. Today, I'd like to share my experience with Qora, an advanced automated stool management system that has made a major difference in patient care, especially in the areas of skin, pressure injury prevention, and infection control, all while decreasing stool leakage and saving nursing time. The Qora kit contains 4 components: a soft silicone indwelling receptacle, a matic hub, a drainage bag, and a power adapter. Here you can see the Qora soft indwelling receptacle Unlike traditional devices, it's made from a gentle, pliable material designed to rest at the anal rectal junction while exerting zero radial pressure. This eliminates the risk of mucosal impairment, rectal trauma, and necrosis. For highly acute patients, it's a significant advancement in providing safe and comfortable care. Instead of relying on manual interventions, the system automatically diverts stool output using negative pressure suction. Think of the wound-based negative pressure or oral and tracheal suctioning. However, the chromatic is an intermittent suction and automatic irrigation device that works in a novel, unintrusive manner. This approach eliminates the risk for leakage, thereby reducing the risk for incontinence-associated dermatitis and hospital-acquired pressure injuries. The automated milking and irrigation can save up to 174 minutes of nursing time per day. This allows us to focus our time and expertise on direct patient care rather than managing containment and device cleanups. You can see the negative suction pulling the fecal down into the matic container here and then into the bag. The matic hub has a smart LED indicator to assist the nurse with troubleshooting. The colored light will illuminate, indicating a need to press either the start button, maybe telling us that the irrigation is in process, that no manipulation is needed. It may tell us the water bag is empty, or there's a need to change the bag. For the acute care setting, the chromatic automated stool management is indicated for fecal management by diverting and collecting liquid or semi-formed stool in the bedridden adult patient. Uninterrupted use of this device, including replacement with other same devices, should not exceed 29 days. Chromatic offers clinically proven improvements in outcomes, patient safety, and nursing burden. Contraindications will look similar to other FDA-cleared fecal devices. The product was invented by a team that had a singular focus on improving incontinence management for over 10 years now. And for any clinician that is battling skin issues, maybe C. diff infections, incontinence-associated dermatitis, and wants their facility to meet and exceed certain quality standards, chromatic is worth the look. It's an effective, evidence-based solution for preventing pressure ulcer injuries and infection while enhancing both nursing workflow efficiency and patient comfort. As we look towards the new CMS quality measure, the ECQM electronic quality measure for hospital harm and pressure injuries, which will then start to include stage 2 pressure injuries, it will be more important for us not to confuse the stage 2 and the incontinence-associated dermatitis. So perhaps it's just time to avoid IID and PI altogether by protecting the patient with zero radial pressure, zero leaks, and zero skin injuries from moisture and pressure. Thank you for your time.
Okay, guys, thank you so much for your collective presentations there. I think we'll start kicking off Teresa and Chris with the questions, which I'm going to do very sophisticated reading of in front of you, even that can do that, but might as well do this. First question is from Anne Cornelius from University Hospitals, Plymouth. A collective question, I suppose. Is there any reason why saline is used to irrigate rather than water?
So saline use for irrigation has been commonplace with most and all, I think, intrarectal balloon catheters. So there's no specific change with the Qora system.
Okay. One from Jisha Sabiush from Wirral University Teaching Hospitals. How often do we need to change the system in the back?
So the system itself can stay in situ for up to a maximum of 29 days. The bags will generally be changed as and when required, but usually within a 24-hour period, we will generally have a change of bag. Bags are nice and easy and quick to change. A quarter rotation click will release the bag, which has a cap to close off, and then the new bag out with a quarter twist and a click back into place.
Teresa, for you from Catherine Stokoe from NHS Highland, do you use the system proactively or when fecal incontinence is present and unable to manage it in other ways?
So yes, we use it when incontinence is present and we're unable to manage it with maybe a simple fecal collector bag.
Okay. I'm Cornelius again. How many patients did you trial it with in your ITU, HTU? Was it better with the sedated patients rather than non-sedated?
I don't have the specific numbers of how many patients we've actually used it on, but I would say it's probably better with sedated patients.
And just here again, have you seen any reduction in your nosocomial C. diff infections since you've started using this?
We are fortunate that we don't really see many patients anymore with C. diff. Mm-hmm. However, if we did have a patient with C. diff, our infection control team would still tell us that we had to use a side room.
Okay, they've actually second
really
question. Yeah, because of the known C. diff cases, that's helped. So
yeah, not really. No, we very rarely see them.
Is there any different in HDU? Do you know, Teresa?
Again, no, we don't see them across the 2 units very much at all. At the moment, it's CPE cases, and they are not always symptomatic.
Okay. Melinda is from Epsom is asking about the webinar being shared in email. Melinda, we'll have the recording ready and communicated to you the next couple of days, so you'll get an email to say it's available to you as well. Yeah, as you see there, my colleague there, that's good. Marcus from Sandwell, West Birmingham. Do you think this is something infection prevention control will be happy to trial in hospitals, or will they need more evidence?
From my point of view, I've had a really good relationship and response from the infection control as well as tissue viability teams in general. They're always looking to help manage situations in a better and more positive light. So I think they're very keen to learn more about these things.
What do you think is the main point, Chris, of what are they most nervous about, did you find?
I wouldn't say it's nervousness, but they're looking to try and manage situations better. I think with fecal incontinence and management of it's always tricky, and we don't have a foolproof system in place yet that completely manages the situation. So I think any improvements we can find along the way are always going to be welcomed.
That's good. Jisha, any reduction in any other enteric infections such as CPE or VRE?
I think we are seeing a rise in CPE cases across the trust at the moment, so it would be difficult to answer that question, and whether we could actually put it down to using the Qora system without having to look to see how many patients we're using it with.
So it's still a work in progress.
Yeah, not all patients are symptomatic.
Interesting. Okay. Teresa, you said it was better in sedated patients as opposed to awake. You are being nudged here. Could you be a bit more specific?
I think that's mainly because obviously you can position your sedated patients a lot better, so you don't have any drainage issues. Your awake patients may not necessarily like the fact it's there. They often won't lay in the position that you want them to be, which is natural, isn't it? We all want to move ourselves around a little bit, so you're more likely to get a bit of overflow. But I think just from that point of view, just because it's technically easier to position your patient better when they're sedated.
Any interesting question from me, I suppose, is do you find different age groups are more comfortable with this process and trial than others?
think more maybe specific patient groups rather than ages.
Really? That's
Yeah.
interesting.
So obviously, your patients with your liver patients, they can be quite agitated anyway. So it's not always easy to work out what's causing the agitation. A lot of it will be invasive devices of any kind that can add to the irritation.
Absolutely. Marcus is backing up that this, how it can be skeptical, skepticism within workforce, which is fine. Sharon Stevens from Plymouth. What do the colorectal surgical team think of these?
Teresa, any ideas?
So just repeat that question again.
What do the colorectal surgical team think of these?
They haven't made any specific comments, really. Nothing that I'm aware of.
When we introduced the Qora system to Harrogate Hospital, the team there wanted to specifically gain opinions from the colorectal team, and they were more than happy to trial the device. And since then, it's been up and running and doing really, really well. So I've not seen any negative comments from them. They all understand the process, the anatomy, the reasons for use, and the design and implementation of it to try and help resolve some of the issues previously noted.
Interesting. Teresa, this is from Nicola Robertson from Gateshead Health NHS. Teresa, with the expulsion of the unit, did you find this happened solely due to anatomical problems, or was there user error as well?
I think we've only had a couple, so I think it was anatomical, because we did discuss this, didn't we, Chris, about a couple of patients. So that's what we decided.
If it's down to user error and application, we're more than happy to help provide further training. It's difficult to get training with all of the staff because there's a lot of staff on a lot of shift rotations. But our representatives will always help to support along the way, just to widen that education and knowledge.
Jisha from Wirral is saying it would be interesting to understand the number of CPE cases in your unit before using and since you started using the system. But whether you want to respond to that, or is it very much something that you covered before, was it?
I think so, yes. I mean, I'd have to go back and look at that, really.
Charlene's reply would a thank you, no different to any fecal management device and patient tolerance. Okay. Melinda from Epsom, do you find that only type 7 stool can be managed with this system, or type 6 is drained without excess of leakage?
I think that definitely type 6 as well is more tolerated by this type of system.
The aim with Qora is to allow for a 5 to 7 on the Bristol stool. So you wouldn't necessarily introduce it for a 5 or possibly even a 6 sometimes, depending on the specifics. But if there's skin integrity issues, then the device can potentially stay in for longer to help those excoriated areas heal better.
Follow up from Jisha, do you think the awake patient could touch the system often due to irritation, and there is a greater chance of transmission of enteric organisms?
I mean, they could touch the system often, but if you haven't got any leakage, then you shouldn't have an issue with transmission.
And would that be any different to any system?
Exactly, yeah. It would depend on the leakage, wouldn't it, I guess?
And Cornelius, would rectal expulsion not sometimes be seen with rectal contraction occurring?
So the idea with the Qora system as well is the position of the lumen is ever so slightly higher. So it stays away from that anal rectal junction, reducing the need for patients to defecate. They don't have that same sensation of the balloon sitting low against the sphincter tone. So they should be less likely to try and push, force, and pass the stool with the system in place. If that answers the question.
Does it, Anne? What do you think, Anne? Does that answer your question? You want to come back with any follow-up comment? To a degree, could be displacement then. Interesting. Any observations on that, Teresa, Chris?
As in during the application?
Yeah. The same to a degree, it could be misplacement then. Anne's pointing out that.
Well, I think the system and the application and the standardization of application is designed so you very, very rarely will get a misplaced device. The white stopper on the application is designed to sit up against the coccyx. So unless it's a new inexperienced nurse who's not familiar with the system and they think maybe they shouldn't quite insert it as far as they do, I don't know. But generally, insertion and removal of the device is a very, very simple task, which I'm sure Teresa will second.
Yeah, definitely. Yeah, I haven't had anybody who hasn't followed the instructions. And I'm only aware of 2 patients that have managed to expel the system. And one of those we decided was anatomical.
Interesting. Just looking to see if there's any more questions. I suppose one of the things that, if there are no more questions, one of the things I could sort of ask both Teresa and Chris really is, obviously we're coming up to end of October now. What are your targets with what you're doing? Where do you see this developing the rest of the year, and what do you hope? Where do you hope to be with this process this time next year? What are your targets?
Well, we aren't using any other system other than the just the external fecal collector bags. We no longer use the flexi seals. We just use the Qora system. So we'll just continue to monitor the effectiveness of it.
It's good to hear. Chris, from you?
So from our point of view, we've got lots of trials and interested centres at the moment. So it's about delivering the message, improving the education, getting out and doing the training with the teams, and making sure they've got all the tools to provide effective fecal management that we can. We recently attended a few of the critical conference network sessions, and we've had a resounding positive experience from them. People are keen to learn more, and they want to trial these systems. So it was a well-timed webinar. So thank you for that. Just to provide better education, knowledge and understanding of what the system is, how it's different and how it works. We've been used to balloon-based systems for a long, long time. So sometimes initiating that change can be challenging.
Well, on that, I think I want to say thank you to both of you and obviously the wider group for contributing to today. The exciting thing about it is that there are well over 100 people that have decided to join the webinar. It's always functioning a live process and a recorded process. So Bilal, my colleague here at NOLEX, he'll gather together all the questions material, all the video content, the slides, and in the next day or two, everybody that's been participating today, you'll get communication to say that recordings available, and the conversation will continue way beyond today. But Teresa, Chris, thank you. Thank you to all our participants today, and I wish you a happy Thursday afternoon, and thanks again. See you all soon.
Thanks for having us, Alan.
Thank you, everyone.
Thank you. Bye-bye now.
Bye.